will be addressing unmet needs in boys with advanced cerebral disease. Could you please welcome Dr. Florian Eichler from Mass General?
Great, wonderful to be here, and what a moment to celebrate together, and just to be here in person, just talking to Jerry. It's like recalibrating on at least myself and you, not seeing everybody has taken away some of my balance. So I'm finding my balance here as I'm joining. So I have the difficult privilege to talk about advanced cerebral ALD, and so some of this will not be easy, but I think it's important. Just briefly on disclosures here. You just saw Connor, and I'm pretty proud that we all got to share this moment together, seeing first commercial gene therapy arrive. So I think much credit to the community at large, and especially with the others. This is success for early stage cerebral ALD. It wouldn't have come without the insights around bone marrow transplantation, all the progress that has been made over decades, and a lot of the data that was concurrently collected for bone marrow transplantation in a cohort also with early stage cerebral ALD, and led to FDA approval last fall. But it does not address what we are still seeing as reality, which is advanced cerebral ALD coming to attention through first symptoms that are leading to the diagnosis. And I want to emphasize here that while we have had success for early stage cerebral ALD, all stages of the disease deserve attention. And this is true for advanced cerebral ALD in childhood as well as in adulthood, where we're still lacking effective treatments and also guidelines for how to work together. And I'm going to attempt to come up with some ideas around what progress here can look like. So what is advanced disease? So advanced disease, for those who are new to this field, we define as a LESS score, which is an MRI, imaging severity score, with 34 points. You have to have more than 9 points to be defined as advanced cerebral disease. There's a neurological function scale that was developed by Dr. Raymond that we also use to point to the symptoms in cerebral ALD, those that lead to major functional disability, here shown in bold, and you have to have 2 or more to be defined as advanced cerebral ALD. Cerebral ALD, as all of you know, is a progressive and relentless disorder of demyelination that spreads through the brain, has a leading edge of even the microphone fails in face of relentless progressive cerebral ALD. But it is important to keep in mind that 12% of cases can halt on their own. And so us obsessing over the MRI and the level of contrast and what we assign as signs of active inflammation is important and key to assessing disease and disease activity. So what does the unmet need in advanced cerebral ALD look like? And I thought I'd start off with some examples here to show you what I think is the kind of symptomatic patient that we see that is really deserves some attention and understanding. A lot of these boys with advanced cerebral ALD have visual and auditory processing problems that impair activities of daily living, like accident here, who, as you can see, is having trouble doing finger, nose, finger, and unable to find my finger in space. In part, this is visual processing. There might be also an element of hemi-neglect here involved. But in short, it is about the failing of these connecting fibers in the brain, and you can see the garland of contrast enhancement on the image on the right. Unmet need in advanced cerebral ALD is also the boys that have trouble with gait, trouble with balance, here you can see one of the boys I've been following for the past year who's increasingly had difficulties ambulating, in addition to being cortically blind and requiring assistance from his father. So I want to point to the fact that beyond the garland of contrast enhancement, his last MRI here with a LES score of 18 also shows enlargement of the ventricles. These are very advanced findings that we have so far not paid much attention to, but it is this biology is also a reality for these boys. And as we think forward, we heard a very nice talk from Eric Malik about the more you look, and the earlier you look, the more you see. I would say the later you look, the more you see as well. And so all of these different stages deserve attention and can reveal something about what is needed and what could be effective treatment management. So my main message here is if there should be a way for us to overcome therapeutic nihilism. What does that mean? That means that there should never be a stage of disease where we think it is too late to do something, too late to have hope. There's still hope, and there's a lot to do. Okay? Not one size fits all. The specific stage of disease and needs of patients dictate the choice of therapeutics. I think just because you don't qualify for gene therapy or you don't qualify for bone marrow transplantation shouldn't take away your right to have appropriate treatment, and a treatment that is tailored to your needs. There's always an opportunity for betterment, and a lot of it has to do with us understanding choices and understanding expectations. Both symptomatic and experimental treatments should be considered in this stages of advanced cerebral ALD. Services, in my mind, become even more important. Occupational therapy, physical therapy, speech, swallow studies. Often physical therapy I bring into the house just to make sure that there's no fall risk, right? So understanding that there are not secondary complications because people are having, patients are having gait and balance problems. Timing is critical. Things are constantly changing when you have advanced cerebral ALD. It's a different type of medicine than in the pre-symptomatic stages. You need to reevaluate everything from month to month. In my experience, whatever I saw in a child can change within weeks. We just evaluated a young man who was going to go through transplant 2 weeks ago. His exam had changed dramatically within a 2-week period. And so really setting expectations and reevaluating regularly is key. So here we have 30 boys with advanced cerebral ALD that were seen in our clinic, shown as horizontal lines, with in blue point being the age at which advanced cerebral ALD was detected, and then the line indicating their current age over time. Several of them have gone through transplantation, and several of them have also died, as indicated by the red dot. So I want to point out that many boys with advanced cerebral ALD often live for decades and with needs that are not well studied in our community. So this is a reality that often is happening at home, with parents having figured out insurance issues, care at home, equipment, devices they need, and it often doesn't make it into medical literature. It's not something that we share best practices around, but it is something I think that affects families, and as they're looking for orientation, as they're looking for what works and what doesn't, I think it would be good to draw attention to it. Many of these boys live long. There are some that also die in short periods of time, often those with more fulminant course, pain, spasticity. Often aggressive treatments are then not chosen, and families may appropriately say, we don't want a G-tube or feeding tube. So there are many choices that are being made, often in very dramatic and tumultuous situations. And those that receive transplants are not always those that live the longest. And there are some boys that burn out and live a long time without transplant. So I do think we have to really look at this data hard and ask ourselves some difficult questions, which is whatever we say about the pre-symptomatic or early stages true for the advanced stage disease as well? All in all, I think what helps me get through the day is having a wonderful team and care team, and I think building community is an integral part of a therapeutic plan. The family supporting each other. Disease affects not only one body, but a whole community. I always emphasize that this is not about just the child, it's about the relationship with the child, how the parents are dealing with the scenario, and the caregiver needs equally important attention. We need to avoid burnout. I want to say that all of the things we have done over the past decades in this population, I couldn't have done without Katie Becker, who's been an incredible partner in all this. Colleagues like Brian Wishart, Physiatry, and many others who've helped, Christy Duncan, of course, who I couldn't have done any of the work on transplant and gene therapy without. So it really requires community everywhere and at every step along the way. We have learned through working across disciplines that there's a lot that can be done. And as we think about pain symptoms, pain affects advanced cerebral ALD to a great deal. And we know it is multifactorial, and you can do a lot about pain by understanding its various different sources. There are not just medications, there are all sorts of tricks from physiatry that can be brought in and assist in the daily living of these patients. We also understand how sleep impacts quality of life, and paying attention to how sleep can improve symptoms. And having just dealt with a young man who was admitted at Children's with fatigue, and having given him 2 days of high-dose hydrocortisone, he is now more awake. He also got melatonin last night, so that might have also helped. So it really contributes to well-being as he's now more awake. Are these things a cure? No, but they're significantly contributing to well-being and influence subsequent choices about experimental treatments. So just to emphasize that while we do understand a lot about sleep management in the early stages, there's still a lot of things that we need to explore about advanced stage ALD that is not well understood. So input from affected families with advanced cerebral ALD is key. When Kelly provided some nice input to Katie Becker as she was reaching out to families about their testimonials. And interestingly, there was a fantastic synergy between the messages both of them were independently receiving. Families care about improving communication, pain, and spasticity management. They want to understand how they need to adapt, not just mentally, but also physically. How does their house have to change as they are trying to bring children home with advanced cerebral ALD? What kind of equipment do they need? And how can local providers be educated? A lot of families say, we need to raise more awareness, educate local providers in order to help my child receive services appropriately. Seizure prevention during transplant was mentioned. Guardianship questions are now popping up again and again, and emotional support. And vision and visual engagement is also rising to the top of the list for families. So just a few of these testimonials that I think are so impressive. Dylan's mom here, communication, of course, is a priority. He's still not really using any devices purposefully. Obviously, we wish he could tell me his needs and wants, but this also means he is pretty unable to engage or interact with people unless he is swimming. There's not really much for him to do, especially in winter. It's hard to get him to engage in any activity. Chase's mother, Robin, some things that are important to us are his vision, which we have been working on. So this visual engagement is a way of maintaining a relationship. His mobility is also very important to us. He receives Botox and he has his hand casted. If he could hold himself up in a sitting position, that would be beneficial for him. Chase tries to speak so much. So I think some of these testimonials from families really help and point to what the family sees as potential, and it might not be within the realm of what we are aiming for with the current outcome measures that we seek, but they're equally important and something we should adapt our eye and our thinking to. Christopher, the human brain is amazing, and I would pray that no one looks at Christopher like it's too late or he's too far gone. I don't believe that for one moment. At diagnosis, we were told that Christopher would be gone within 3 years, and here we are 6 years later. Christopher is the strongest person I've ever met in my life. So this is a young boy who was diagnosed at 7 years of life, and he's spent 7 years now bedridden, but receiving amazing care from his family, and the love and care is really palpable. Turning to men with advanced cerebral ALD, while we often think of progression of cerebral ALD in equal terms as boys, in my experience here with 13 boys men outlined here, their decline is often quicker than I had expected. And when men with advanced cerebral ALD present, it's curious, half of these men have actually known that they have had ALD in the past. But I cringe a little bit when we start to say that men should not continue to have yearly MRIs, because I do think this is an important part of care and monitoring that should continue into adulthood. Is it possible to space out imaging from 1 year to 2 years? I probably take the more pragmatic approach I've learned from Jerry Raymond. Just keep it simple, right? Do it once a year, and if they miss one, so be it. But keep it simple, and this way you don't miss somebody and then years later you find out that they all of a sudden have advanced cerebral ALD and options are limited. Why are these men declining so quickly? I think this is something we still need to look into more. I think there are psychiatric issues, poor self-esteem, concurrent myelopathy, comorbidities of aging. Some of them have had cardiac issues. But all of these factors contribute. More recently, we've done an insurance claims database study looking at more than 300 adult men for adrenal myelopathy, but I venture to say that some of these are also affected by cerebral ALD. Why do I say that? Mortality rates are 5 times higher for ages 18 to 64 and 2 times higher for above 65. And men are at a younger age at death here. So there is a clear burden of illness here, and I think we don't really understand all of the factors that are contributing and coming together here. While I'm in New York, I often think of a young, talented man that also Eric has cared for, 41-year-old chemistry professor who was in a car accident thereafter, got more confused, had gait changes. A year later, 2 generalized tonic-clonic seizures, and due to decline was decided not to transplant. visual processing declines, confusion, circular conversation, urinary incontinence. So you can see a rapid decline, very similar to in boys, but in my experience, some of these men are even more fragile, and their survival is less guaranteed than in some of the boys I see. Ronnie is a man much beloved by his family, and when his wife reached out to say what she would share, I would say the most frustrating part for Ron was getting the equipment he needed before he progressed past it. Maybe more specialists in more areas are needed. So equipment is huge, and the lack of knowledge in the community, I think, is something that she highlighted. One thing I want to point to is growing literature in the German community that has really highlighted that while transplantations are possible and can halt disease in adults, it's more difficult than in the boys. And here, Wolfgang Köhler and Jörn Kühl have pointed to the fact that involvement of cerebellum and thalamus is a poor prognostic factor going into transplantation. Just to highlight that while a lot of the things we do in pre-symptomatic or early stages is very difficult for advanced stage cerebral ALD, neuropsychological testing is often not possible anymore. So I think there's a lot that can be learned from neuropsych testing, but can we still do it in advanced cerebral ALD? I would say in many cases we can't. And similarly, MRIs, often sedation is not tolerated anymore. So how do we think about that? How can we adapt to the needs in this advanced cerebral ALD population? I was talking earlier to Sumit about the fact that we could do motion-corrected MRIs, save on sedation. What I do know is that we need to pay attention to these patients who have true needs. So we've been trying to understand communication by looking at visual impairment and vision symptoms in patients with cerebral ALD. And the exam findings of visual impairment are very common in cerebral ALD, and these range from everything from what we call lower order vision changes, which are those that impact eye movements, visual acuity, to those that really rely on the integrative function of networks involved in visual pathways. So visual integration, visual processing, all of those we count as higher order symptoms. And this is a nice list that was put together from our MGH cohort from neurology and neuropsychology notes. It is also clear that visual deficits become more prominent as your less score rises. You can see here some of the numbers around visual deficits rising here from 50% to 85% in advanced cerebral ALD, and then looking at the various different higher order and lower order vision symptoms. So we've started working with Mass Eye and Ear that have specialists in visual processing and what they call cerebral visual impairment, and have asked them how to measure symptoms. And I'm particularly excited about doing this in patients who might not be able to communicate, might be nonverbal, and maybe we still have a chance to assess what is going on in their brains, knowing that white matter is affected, knowing that these visual pathways are undercut. And so we're starting to use a virtual reality and eye tracking system where patients are now starting to reveal some of their functional vision by engaging in specific tasks that allow us to measure reaction times and through the eye tracking paradigms we use. We have a simple laptop that we put in front of them and ask them to perform tasks such as the virtual hallway task here, where patients are asked to track, for instance here, a schoolmaster principal through a hallway, and this hallway is then has more and more people stepping out into this hallway, becomes a realm of increasing complexity. And the discovery here really is that the more complex the environment, the harder it is for patients with brain disease to track and follow. And this is not surprising. When I'm in clinic, I often notice that it's harder for signals to get through to the brain, for the patients to react in a timely fashion, to hear in a timely fashion. You have to have much more patience to have that signal come back. So when we start to then quantify that, really an interesting observation for me is that some of the symptoms of cerebral ALD that we might be attributing to attention deficit, particularly in the early stages of cerebral ALD, may be better characterized as cerebral visual impairment. And why do I say that? And when we compare the kinds of eye tracking paradigms here to patient populations that are affected by ADHD and don't have ALD, shown here in yellow, compared to the cerebral ALD population shown in green, the cerebral ALD population has a worse success rate in being on target and identifying moving objects on the screen. And their reaction time is also slower, as shown in the middle graph. This is quite different from ADHD patients who are quicker. And also when you increase the complexity and look at this reaction time, there's also a difference that emerges. You can see here in green that the cerebral ALD patients, as complexity increases, they are clearly worse than the controls, but they don't, and they get incrementally worse as you increase complexity, but they're not as distractible as the ADHD population shown in yellow. So it's all fine when you look at a screen with this hallway paradigm. The next thing we're asking ourselves is, what does this have to do with real-time, real-world scenarios? And so Lotfi Marab at Mass Eye and Ear is now working on Tobii eye tracking glasses that allow you to use infrared sensors that track eye movements, and you can calibrate that quite easily by holding a light or another object in front of the visual field, and then watch where does the eye go and what are patients actually tracking. And it's quite interesting because I think it starts revealing how this patient is taking in the surrounding environment, the visual world, and particularly thinking about things like a 9-hole peg or taking objects. You can see that the eye always is going to the object before the hand reaches and grabs it. So you really have an opportunity here to start understanding and tracking real-life experience through an ability to track visual processing phenomena. So I know this was just a quick overview of some of the things that we're thinking about here, but acknowledging complexity, I think, is really important for the field of advanced cerebral ALD. Not one size fits all, but also every stage and every week and every month brings change. What I do know is that we need a multidisciplinary approach here. We need different specialists to bring in that expertise, whether it's the services chiming in, physiatry giving their input. And there's much room for new strategic trials and innovation. I hope we don't shy away from coming up with treatment and trial designs for this population. Appropriate outcome measures are needed. We might not be using the same outcome measures that we're thinking about for early stage cerebral ALD or what has worked for gene therapy trials. We might need to think about visual processing measures, auditory processing measures, things that are relevant and meaningful in daily life. Family priorities are access to equipment and resources, raising awareness, management of pain, communication, vision, and visual engagement. So I'm at the top of my talk, and thanks for your attention. Glad to take any questions.
Thank you very much. I was wondering if you could talk, a little about what are the common presentations that you see, or what does it look like when you first see an adult with cerebral disease?
Yeah, I'm not sure I would say it's all that different from what I see in a boy with advanced cerebral ALD, but it is often personality changes or processing problems, visual processing problems, gait difficulties, and they can often come in a rapid succession. Sometimes it's tricky to tease apart what is visual processing versus hemi-neglect, what are personality changes and compared to real preferences. So things can be quite dynamic. Yeah.
Thank you.
Thanks, Florian. That was nice. I see this as probably one of the top needs for the whole community. I mean, these are orphans among orphans, really, these patients. I was interested to hear your comment about the rapid progression in the adults, because that hasn't been how we've often talked about it, and as we often discover, the way we talk about things is often not quite capturing reality much of the time. But it's your, maybe can you comment a little bit more on what you think about the rate of progression? Is this a qualitative sense of things? You did have looks like some quantitative figures. Are symptoms progressing without radiologic changes in your experience, or is it the MRI changes with the symptoms and they spiral down together? I guess I'm asking partly just as we wonder about how do we measure for biomarkers and for other outcomes in trials. I guess what ultimately the clinical experience matters more than anything else, but how are you thinking about it?
Yeah, thanks, Keith, for the question. So I'm going to give an incomplete answer, in part because we don't get serial imaging in all cases. I don't know, how some of these things systematically progress over time. What I will say is that boys that have advanced cerebral ALD, they can burn out and remain stable and well cared for, and they will, be embraced by their parents and be cared for and live in a state with fully care dependent for many years, and I don't see that happen as often in adults for one reason or another, right? And so my sense is that when the adults decline, I have not seen it bottom out as in plateau. There is really a sense that is it the comorbidities? Is it the medical issues? Is it poor self-esteem? There's a myriad of poor judgment issues that conflict things, socioeconomic, psychological, divorce. All these things play in. Whereas there's a certain resilience with the boys that might, be even important in these advanced stages of ALD. But all of this is a bit just an impression and guesswork on my part. Troy.
That's a nice summary, Florian. I'll pose a question to you that I get a lot about the children with advanced disease pre or post-transplant that are kind of at this semi-arrested state where they don't progress any further, but they're pretty affected. What to do when the parents die?
Yeah.
Like, that's a real question that comes up a lot, and I
Yes.
personally struggle with answers for them, but I don't know if you've encountered that.
Oh, all the time. So a big worry that the parents express is, what will happen to Johnny when I'm gone, right? And so they care so lovingly for him, but it's a real burden on their minds, and they're constantly thinking about that. And I think you're spot on. I don't have a good answer for that. but it's not new. I mean, I think Jerry and others can speak to that Lorenzo, I mean, outlived at least his I think his mother and maybe his father as well. But yeah, so I think these are. It is curious how we do. And again, you cannot generalize, but there is a sense that if you have that fulminant course, and you often then you die or you live for a long time, with support. Katie.
I just wanted to ask for you to comment on the fact that the men that were caught early, and whether or not there is still hope and reason, because even though that data looks not great, I think you've also had experience, right? We've had experience with men that have been caught early and like boys can do well. So for men listening and watching this, I think the message you would say is get your MRI, not give up.
Yeah, so I do hope that while this was a difficult topic, and data is hard to digest, it should send a message that keeping on top of your monitoring, capturing cerebral ALD early, when you can have very effective transplants, and the German group has gotten better and better in doing this, and I think that we have had effective transplants at Mass General, and there's good reason to think if you do it at an early appropriate stage, it works. It's just once you have advanced disease and you're fighting battle on multiple fronts, it is very hard to do all these aspects of biology and life justice.